Madam, good evening, ma'am. Am I audible, please? Ma'am, good evening.
Yeah, good evening, sir.
Yes, sir. Audible. Audible.
We can start, Dr. Vishal now.
Sir, with your permission, President Dr. Naveen Malhotra, sir, should we start today's webinar, sir?
Please go ahead.
Thank you very much, sir. Dr. Sunil, please go ahead.
Good evening, sir.
Please go ahead, Dr. Sunil.
Yes. Yeah. Good evening, all. Welcome to the Research Society of Anaesthesiology webinar series 2025, regards from the RSA Telangana branch. So myself, I am Dr. N. Sunil Kumar, Assistant Professor of Anaesthesiology in Usmania General Hospital. Will be moderating today's session basically. So I'm pleased to and pleasure to welcome Dr. Naveen Malhotra, sir, President, Research Society of Anaesthesiology, and Dr. Vishal Singh, sir, Secretary, Research Society of Anaesthesiology, and Dr. Madhavi, Madam, Webinar Coordinator. So for today's evening, we have the chairpersons, Dr. Pratibha Natarajan, Dr. P. Nagalakshmi, Madam, Dr. Ayash Shamsundar, sir. So I request Madhavi, Madam, to just introduce the chairpersons and speakers, Madam.
Good evening, everyone. I welcome all the faculty. Good evening, sir. Naveen Malhotra, sir, Vishal, sir, all the faculty and chairpersons to the webinar, which is very useful for postgraduates, people who are working in and out in outside practice and medical colleges. Without the ultrasound, we are not able to do anything. So it has become a stethoscope to everybody, especially anesthesiologists, IC, intensivists, and ER rooms. So now I welcome Dr. Naveen Malhotra to address the webinar.
Very good evening to all of you, and wish you all a very happy Navratras. And may Ma Saraswati bless us all, and we all follow the righteous path of knowledge. I am very happy that we are conducting this webinar under the auspices of ISA Telangana State Branch, RSAP Telangana State Branch, and with very dear Dr. Madhvi Julakanti and Dr. Ayappa, Dr. Sunil, and very respected Dr. Pavani as the moderators and the faculty members, and our RSA Puducherry branch office bearers, Dr. Pratibha, Dr. Nagalakshmi as chairpersons. So the topics are very good. Role of USG in anesthesiology pertaining to airway, lungs, and echocardiography. I look forward to listening to you all as a student, and I'm very sure that we will have more such webinars under the banner of Research Society of Anaesthesiology, Telangana, and neighboring branches. Thank you very much, and thank you to the faculty for joining us today. Happy Navratras once again. Thank you.
Sir, now I request Vishal sir to address the faculty delegates.
Good evening, everyone. Thank you to each and every one of you for coming here to join with us in this evening full of academics. Ultrasound in anesthesiology is, I'm sure, a very emerging topic, and everybody of us likes working with ultrasound. As Madam has already said, that it works as a stethoscope for most of us in anesthesia. I especially would like to welcome our patron, Dr. Tej K. Kaul, sir, especially Dr. Pavni ma'am, Dr. Pratibha madam, Dr. P. Nagalakshmi ma'am, Dr. Ayam, Dr. Venu Gopal sir, and Dr. Sunil. And this webinar has been so wonderfully crafted and so wonderfully executed by under the guidance of Dr. Madhvi Julakanti ma'am, under the banner of RSA Telangana. So not taking much of your time, I wish you all the very best of luck, and please go ahead. We would like to listen to the wonderful academics.
And I'm pleased to have our patron, Professor Tejke, call with us. So, sir, few words from your side as blessings on the auspicious occasion of Navratras and the academic activities under the banner of Research Society of Anaesthesiology. Dr. Call, please.
Good evening, everybody. A great effort by the RSS to have started these type of academic programs which are most relevant and which is the demand of the day. Everyone has to have knowledge about ultrasonography because, as already said, that it is going to be almost to be the stethoscope is to be replaced by the ultrasound. I wish Telangana branch of RSS and very good beginning. They've started it for these basic subjects, basic things what is needed of an anesthetist. And I would request the speakers to lay stress upon the basic, how to use the ultrasound, how do we differentiate a bone, a fluid, blood, pus, muscle, nerve, vein. That would be more interesting because I would be benefited. Thank you very much for having already started it on the auspicious days of the Navratra. Wish you all a happy Navratra. Thank you. God bless you all. Best wishes.
Thank you very much, sir. Over to you, Dr. Sunil.
Yeah, thank you all, sir, for pleasant welcome note. So to start up on the session, Dr. Madhavi Madam will be the webinar coordinator. Chairpersons will be Dr. Pratibha Natarajan, P. Nagalakshmi, and Shyam Sundar, sir. And speakers to give an overview of the webinar. I myself, Dr. Sunil Kumar, will be talking on airway ultrasound, and Dr. Pavani Kalyanam Madam, Professor HOD Medak, will be talking on lung ultrasound, and Dr. Venugopal Kulkarni sir from Sindhu Hospital will be talking on the echo. So to start upon with, so we'll start with the airway ultrasound.
I request Dr. Pratibha to introduce Sunil.
So it's really nice to be here, especially with senior members like Naveen sir, Vishal sir, and a whole of RSA Telangana. So I take this opportunity to introduce Dr. N. Sunil Kumar. So he has completed his IDCCM and EDIC, and his areas of interest are focus on anesthesia and ICU, transplant anesthesia, and mechanical ventilation ECMO. He has got about 10 articles and 5 chapters in reputed journals and books. And he's also contributed to the position statement on focus in the ICU. Today, he'll be talking to us on airway ultrasound. Over to you, Dr. Sunil. Dr. Sunil?
Dr. Sunil, you're muted, please. Unmute yourself, Dr. Sunil.
Yeah, I'm audible, sir.
Yes, you are very much audible. Please share your screen. Please share your screen.
Is my screen visible, sir?
Yes, it's visible. Please go ahead.
Yeah. Thank you very much, ma'am, for the kind introduction. Today we'll be talking on airway ultrasound. Basically, we know about the difficult airway management and all. It leaves always a nightmare for us whenever we are dealing with the difficult
Dr. Sunil,
airway.
please make your screen full screen.
Yeah, did it, sir?
this it's not full screen this way. Anyways, go ahead. Please go ahead.
Yeah,
The
I have
the button.
already made
Yes,
slide sharing, sir. Is it visible, sir, now?
it's not full screen.
One second, sir.
I think you have not pressed this button close to 64% on the right bottom side. 64% के बिल्कुल साथ वाला button दबाइए please. It is not pressed, I think.
नहीं
64.
नहीं,
Yes, this one.
I'm sharing, sir, the same way. I'm showing the slide view basically. One second, sir. I've done it again, sir. Is it visible now?
It's not full screen, but doesn't matter. You continue with them, and so your second screen second slide is visible. Please go ahead.
Yes, sir. Approximately around 50% of all difficult tracheal intubations are unanticipated. When you look at the standard bedside tests, there are the poor indicators for the difficult tracheal intubations actually. So the frequency of failed intubations is around 1 in 2000 in elective settings and 1 in 50 to 100 in emergency rooms or the ICUs. The incidence of cannot intubate, cannot ventilate is around 0.1 to 2% among the 10,000s, and 1 in 200 land up in an emergency airway in them. The overall incidence of death or brain death from the airway event is around 38-fold in ER and 58-fold in ICUs. It's way high than the anesthesia. Coming to the Indian statistics, difficult intubations are common in ICUs and EDs among around 8 to 13%, and the incidence of complications is around 22 to 54%. Two or more attempts, always we have increased risk of complications, and esophageal intubation is most common cause of the cardiac arrest, and it increases the sevenfold increase in death of the patients basically. So, though upper airway is an extraordinarily complex anatomical region, preparing for the difficult airway is mandatory, and ultrasound has been as an armamentarium for the in the airway ultrasound basically. So ultrasound is important because and it has multiple advantages like it is fast, safe, non-invasive, reliable, repeatable, and transportable. So I have divided this topic into sonoanatomy of airway, pre-intubation airway assessment, real-time monitoring of intubation, pre-extubation airway assessment, and ultrasound guided airway procedures. So to look into the airway anatomy, sonoanatomy of airway, the sonoanatomy is being divided into suprahyoid views, thyrohyoid view, cricothyroid view, and the
Dr.
suprasternal
Sumit,
views.
your slides are not moving.
Okay, madam. 1 second, madam. I'll just close the PPT and
Yeah.
launch it again.
Yeah.
Yeah, now, madam.
Now it is full screen. Yeah, you can go ahead.
It is
Now
okay.
it's good. Yeah.
Yes, it's okay now.
Yeah. So we have discussed about the sonar views of the upper airway, and for the pre-intubation airway assessment, when we look at the muscles and connective tissue will be seen as hypoechoic and heterogeneous. Gland will be seen as isoechoic and homogeneous, and the bone will be seen as hyperechoic and with hypoechoic shadow below it, and cartilages are seen as homogeneous hypoechoic areas. And air mucosal interface will be seen as hyperechoic linear appearance, and air filled spaces will be seen with the reverberation artifacts in them. To start with, we'll start with the visualization of the tongue. We place the probe just below the mentum in the transverse plane, and we can see the base of the tongue here. And when we turn the probe into sagittal plane with the pointer cephalad, then we can measure the thickness of the base of the tongue here, and also look into the hyomental distance. So this is the hyomental distance where we can measure it, and this is the thickness of the tongue where we can measure it in this plane. And when we slide the probe in the neck below down in the transverse plane, we can see a irregularly margined hyperechoic structure. That is the bone, that is a hyoid bone with a shadow below it. And these are the irregular margins are the cornea of the hyoid bone. And in the same plane, when you tilt the probe a little caudally, you can see a hypoechoic area surrounded by the hyperechoic areas. This is the epiglottis and the pre-epiglottic space. In this plane, we can measure the skin to hyoid bone distance and the skin to epiglottis distance, and this adds to the anterior neck thickness. Any anterior neck thickness beyond 2.8 centimeters, we are always dealing with a difficult laryngoscopy. This is the various domains what we discuss about whenever we are doing an airway ultrasound. Basically, we divide airway ultrasound into three different domains: the anatomical position domain, the anterior neck soft tissue thickness domain, and the oral space domain. And we have multiple parameters in them, and one among them we'll be discussing the hyomental distance, which is most popular among the anatomical position domain. Any hyomental distance less than 5.29 centimeters predicts a difficult laryngoscopy and difficult intubation. And in soft tissue thickness domain, distance from the skin to epiglottis, anything beyond 2.4 centimeters predicts the difficult laryngoscopy again. In oral space domain, tongue thickness, anything more than 6.1 centimeters predicts a difficult intubation. To summarize all these things, and we form a DARES protocol, that is the difficult airway evaluation with sonography protocol, where we look into different parameters like distance from the skin to epiglottis, hyomental distance in extended position, and hyomental distance with the ramped position. So we can go step by step and look into whether we are dealing with the difficult airway. So after looking into the various parameters of assessing for the difficult airway, we slide down in the neck and we can visualize the thyroid cartilage, which will be seen as the inverted V-shaped cartilage with the false sucal cords in the center. And when you slide down further in the neck, you can see a hyperechoic line with the reverberation artifacts below it. This will be your cricothyroid membrane. When you further slide down in the neck, you can see a inverted U-shaped structure. This is the cricoid cartilage. And further sliding down in the neck, you can see the tracheal cartilages as dual hyperechoic lines with the hypoechoic center between. So at the level of the thyroid cartilage, we can make out the thyroid integrity and the vocal cord movements. So whenever we have a polytrauma case or something, then we can look into the thyroid integrity. There may be a thyroid cartilage fractures, which may lead into difficult extubations and all. At the same plane, we can look into the vocal cords also, where we can see the vocal cord movements, and we can see here the symmetrical vocal cord movements happening. In the same plane, we can make out whether there is any vocal cord lag behind or vocal cord palsy happening in our patients. You further slide down, we can make out the inverted U shape, that is a cricoid cartilage. And this is very important to make out the cricothyroid membrane. So we make out a thyroid cartilage, we make out a cricoid cartilage, and we identify the cricothyroid membrane. Identifying the cricothyroid membrane in literature, there are almost like two ways of looking into it, like string of pearls technique and thyroid airline, cricoid airline technique. We'll try to look into this after few slides. With moving on with the anatomy part, in the sagittal plane, when we place the probe in with the pointer towards the cephalad, And we can see something like this. This is the thyroid cartilage, hypoechoic cartilage, and another hypoechoic cartilage. This is the cricoid cartilage with the cricothyroid membrane in between in the sagittal plane. In the transverse plane, we can see something like this, a hyperechoic line with the reverberation artifacts just below the thyroid cartilage and above the cricoid cartilage. So further moving down in the neck into the suprasternal notch, we can see anatomy something like this. The trachea will be in the center, the thyroid glands on the side bys. You can see the carotids and the collapsing IJV. And you can see a small collapsed tube-like structure just behind the trachea. This is our esophagus. So to zoom in, you can see a small collapsed tube-like structure. This is our esophagus, where it has been marked with the white yellow asterisks in the picture. This view is very important to look into the tracheal intubations or the esophageal intubations and measuring the tracheal diameter. So in the suprasternal notch, we take the outer tracheal diameter and we can anticipate the size of the ET tube or size of the double lumen tube basically. And this view is very important again to make out the real-time monitoring of our tracheal intubations. When we place the probe in the suprasternal notch, once we are doing a tracheal intubation, there will be some reverberations happening in the tracheal mucosa, where the esophagus will be a standby. If we are doing a esophageal intubation, then there won't be any reverberations happening in the tracheal mucosa, and we can see a double tube sign almost like this, a tube beside the trachea. This view is again very important for the focus in airway because we can make out on the real-time basis the tracheal intubations. Though capnography is like gold standard, but still to get the capnographic waveforms, we need to ventilate our patients at least to 4 to 5 breaths. But before ventilating the patient, we can make out easily on ultrasound whether we are able to do the tracheal intubations or not. This avoids aspiration again. So these were the studies where they tried to look into the a comparison between the capnography to the ultrasound airway looking into for tracheal intubations. They found that tracheal ultrasound is no inferior to capnography in these studies. We can also make out the endotracheal tube positioning, whether it is above the carina or not. Whenever we intubate, we can just look into the movement of the lung on the bilateral, both the sides, and movement of the diaphragm on the both the sides. If, of course, if there is no lung pathology, we will be able to see the diaphragmatic movement equally on the both the sides. If this is so, then we are sure, sir, that we have not done an endobronchial intubation. We can also make out the cuff position of the ET tube. We can
just a second, sir. All the members are kindly requested to mute yourself. Please do not disturb the speaker.
Yeah. In the suprasternal notch, we can also make out the cuff position of the ET tube. We can instill some amount of saline. In the video, you can see the saline going into the cuff and where the small air bubbles can be seen. And you can differentiate the ET tube cuff per se. So with this, we can make out the ET tube cuff position. This is again very important when we are planning for a tracheostomy. We need to position our ET tube, and many a times we puncture the ET tube cuff while doing a percutaneous tracheostomy. So we can position our ET tube by looking into the cuff position of the ET tube by instilling some amount of saline into it. This was all when we had a cuffed ET tube. This was a study done on pediatric patients where they tried to look into on a daily basis whether we can make out the ET tube position in terms of or with respect to the aortic arch. Whenever we place the probe in the suprasternal notch with the pointer cephalad, we can be able to see aortic notch here and a hyperechoic line. This is our ET tube. We can measure the distance of tip of the ET tube to the aortic arch so that on a daily basis, we can monitor the position of the ET tube without taking an X-ray also. So these were all the importance of using the airway ultrasound and looking into various aspects. And once we have used it for the monitoring and all, we can also use airway ultrasound for pre-extubation assessments also. because many a times we land up with post-extubation striders in our patients. We usually do cuff leak test to measure the or identify the patients with post-extubation striders. But we can also utilize laryngeal air column width, where there will be a small air column in front of the ET tube, which we can measure by putting the probe in the cricothyroid membrane or suprasternal notch and look into the air column width. The air column width will be seen as hyperechoic line with a shadow casting behind. So we can measure the air column width and get a ratio out of it. So what we usually do is in ICUs, whenever we intubate a patient, we measure the air column width and document it. So we get an air column width after intubation. And after few days, when we are planning for an extubation, we can again measure the air column width just before extubation. We can take a air column width ratio. If the ratio is less than or equal to 0.8, then we may have a patient with post-extubation stress. Those studies have not proven air column width ratio to be like 100% specific and sensitive, but it can be added with a cuff leak test and have a better outcome out of in our patients. Then we can also utilize the ultrasound for guiding us for airway procedures basically. And we will try to look into the string of pearl techniques of how to make out the tracheal rings and how to make out the cricothyroid membrane. So to learn upon, we place the linear probe in the suprasternal notch in the transverse plane. So we see something like this, a trachea in the center. Then we move the probe onto the right side so that the trachea comes on the one half of the screen, and turn the probe into 90 degrees to stay in the center. So when we are in the center with the pointer cephalad, then we'll be able to see something like this. These are the string of pearls or the tracheal rings. So uh, we move the probe cephalad to see the first bump coming. This is the cricoid cartilage away from the tracheal rings. So you move further cephalad to make out the cricothyroid membrane. So this is how we make out the cricothyroid membrane and the tracheal rings in the string of pearls technique. We can mark the tracheal rings where we can do the tracheostomies also. We can plan for the tracheostomies also. Or we can mark the cricothyroid membrane prior itself in difficult airway patients. And coming to the thyroid airline, cricoid airline technique, we place the probe in the transverse plane to identify the thyroid cartilage as inverted V-shaped structure. We move down cephalady the probe to make out the air mucosal interface with the reverberation artifacts. We further move down cephalad to make out the cricoid cartilage as inverted U-shaped, and then we move cephalad to mark the cricothyroid membrane. These are the two techniques which are identified and explained in the literature to identify the cricothyroid membrane. We can utilize this for the ultrasound for the assessment before the tracheostomies also. Most of the cases we do neck ultrasound before doing a percutaneous tracheostomy to identify the surface sononatomy, to look into the abnormal vessels in front of the trachea, to mark the tracheal rings where we have to do the tracheostomy, and to position our ET tube to identify the real-time needle insertion into the tracheal cartilages and to confirm the guide wire placements. So this was one of our case where we tried to look into the we were screening prior to the percutaneous tracheostomy, and we found such a big abnormal vessel just in front of the trachea. Though it may not be visible for the naked eyes, ultrasound throws some light and we can look into such abnormal vessels and avoid complications while doing percutaneous tracheostomies. So my take-home message would be the ultrasound has become an inherent armamentarium of anesthesiologists or the intensivists. It has become a tool to assess the airway in critically ill patients and assessing for the airway, and helps in detecting complications earlier and troubleshooting these patients, and helps in performing procedures with great accuracy. Though it looks like we using an ultrasound is a sophistication nowadays, but this will be a standard of care for tomorrow. So do not stop here. Go back to your units, read about it, keep on practicing. You will have many, I mean, you may not get it for the first time. Read a practice, and you will be mastering the airway ultrasound. Thank you.
Dr. Sunil,
Yes.
Dr. Pratibha here. So
Yes.
I just want to add up, like actually you were mentioning about the laryngeal column width, right? The air column.
Yes, ma'am.
So basically it was started for pediatric cases actually, right?
Yes, ma'am.
So one article which it mentions actually like even if you do your standard cuff leak test, which is
Yes.
a 100 ml, if there is 100 ml leak also, but if you try and do your air column width,
Yes,
they
ma'am.
say that, and if your air column width is definitely less than 0.8, the ratio is less than 0.8,
Yes, ma'am.
that is your post extubation stridor is almost 0%. That is what they have told. So no, we are usually having the habit of both in the operation theater as well as in the ICU.
Yes, ma'am.
We just do the cuff leak test. But with our airway ultrasound, I think we need to move forward. You know, like we even if there is a leak, we'll be really scared. Okay, we
Yes.
must. But then with this, we can definitely extubate the patient.
Yes, ma'am.
And if you're going to combine this with the diaphragm ultrasound, obviously we'll have upper hand in extubating the patient.
Yes, madam. Yes, ma'am. Very true. I have not touched into few more
Yeah.
aspects like we can even measure for the subglottic secretions in our patients on a daily basis and do the subglottic suctionings and avoid VAP happening in these patients. And I have not touched into postprandial status of the patient. We can also look into the prandial status of the patients also. So with the constraint of, I just ticked over to the airway ultrasound per se, but we can utilize in many ways to make out all these things.
Thank you, Dr. Sunil.
Thank you very much, madam. Thank you.
Sir, we'll take the questions in the end, sir. Now I request Dr. Shyam Sundar sir to introduce Dr. Pavani ma'am.
Yes, good evening all. It's privilege to introduce Dr.
చదువుకోలేదు నువ్వేమో మళ్ళీ చదువుకుంటాండావు అంటున్నావు అందుకని అన్నా
Dr. Ranga Srinivasa Chitra. Can you mute your mic, please? Yeah, thank you. Professor Pavani madam is also one of my teacher, and we learned many things from her. She has been worked with so many years worked in Usmania Medical College in Hyderabad. Later, recently, she moved to the other center, that is Medak Government Medical College in Medak, and she is heading the department there. And she has a lot of interest in educating kids. So many times she organized the various academic events. And ma'am also one of the seasoned faculty for our conferences. And madam's area of interest are difficult airway management, organ transplantation, and pain management. With this brief introduction, I request Pavani madam to present her topic, that is lung ultrasound. Ma'am.
Good evening, everyone. At the outset, I would like to thank the organizers of Research Society of Anaesthesiology for giving me this opportunity for this presentation. And thank you very much for the kind introduction, Dr. Shyam. So today I will be talking about lung ultrasound.
Share your video, madam.
Yes, I'm starting. One second.
Madam, it is a great privilege for the Research Society of Anaesthesiology as well for you to be a part of this platform, ma'am. Thank you very much.
Thank you so much, sir. Thank you, sir. Thank you very much. So today we'll be talking about focused. Sir, are you able to see my screen, sir?
Yes, ma'am. Yes.
Okay. So today I'll be talking about focused lung ultrasound. So in recent years, a lung ultrasound has become popular as a clinical point of care tool in a variety of settings. The latest developments in lung ultrasound are based on the interpretation of a few signs, which are mostly artifacts rather than technological advances. Especially, it is very interesting for intensivists, anesthesiologists, emergency medicine physicians, pulmonologists, and radiologists to have the ultrasound at availability. So the history dates back to just 1994 when Targeta discovered the B lines in diseased lungs. Daniel Lichtenstein was a French person who has correlated the ultrasound B lines with the CT data of interstitial edema and pulmonary fibrosis. And this marks the modern era of ultrasound birth. So in 2004, Picano and Jambrick correlated the extravascular lung water in the chest X-ray with the B lines of the lung ultrasound. And since then, there have been a lot of developments. And actually, in the beginning, people were hesitating because we don't have any positive signs in lung ultrasound. But recently, because of the detection of a lot of artifacts, lung ultrasound is being widely used now. So the indications for ultrasound include diagnostic as well as therapeutic things. So here the diagnostic, you can evaluate acute dyspnea, evaluate the lung disorders. It can be used in airway management and also in the cardiac arrest. Therapeutic is, it acts as a guide for interventional procedures and as a guide to mechanical ventilation. Advantages of lung ultrasound, as Dr. Sudhir has already mentioned, it is non-invasive and non-ionizing, bedside. Portable ultrasounds are easily available these days, and it is easy to learn and easy to perform. It is repeatable and potentially life-saving in emergencies. And finally, it is cost-effective and time-effective. And it is suitable for evaluation in many settings. It can be used in the outpatient department, in the wards, in the ICU, in the emergency department. It can be used for acute as well as for chronic conditions. So the limitations of the lung ultrasound are, it cannot detect the lesions that are deep and intrapulmonary, and it is difficult in obese patients because of the thickness of the rib cage. Subcutaneous emphysema or large thoracic dressings preclude the propagation of the ultrasound beams. So now we will be talking about focused ultrasound. So I am not going into the discussion of all the lesions of the lung, but I will only focus on a few important acute conditions. So the point of care ultrasound, which has come into vogue recently, is ultrasonography brought to the patient and performed by the provider in real time. And focused lung ultrasound is the term used in the same context. It is defined as ultrasonography performed in a focused manner in order to answer certain specific and clinically relevant yes or no questions. So the equipment that we require is the ultrasound system. We have the ultrasound machine. Any basic ultrasound machine can be used. And the 2D mode and the M mode, if they are there in the ultrasound machine, that is enough. And transducer selection, any of the transducers can be used. The curved array, the linear, the phased array, or the microconvex can be used. And preset selection, if the machine has a flush selection, you can use it. Or an abdominal can be used for the pleural detection of pleural effusion, musculoskeletal or superficial for the lesions at the pleura. And the orientation marker presentation on the screen can be either left or right. So these are the various transducers that you can see. So any of these can be used depending upon the area you are trying to detect. And the skills include actually ultrasound is operator dependent. So improvement of the skills is very important to operate the ultrasound. So placement of the transducer and finding the right windows, optimization of the ultrasound image by changing the depth, gain, and focus, identifying the structures and looking for pathology. So recently, 4 levels of skills and knowledge have been hypothesized and they are under investigation. Based on the expertise of the physicians who is performing the ultrasound. So the basic skills have to be mastered by all of us in anesthesiologists so that we can utilize it in the operating room or in the ICUs. The next level is the intermediate level, further is the advanced and the expert, and the research has to confirm this hypothesis of the various grading of the skills. So now coming to FLUS, or as I said, the focused lung ultrasound, it is used to diagnose and exclude acute, potentially life-threatening conditions in the ICU, the emergency department, or in the OR. And here the scanning is limited to a particular, scanning is limited to part of the surface of the lung and the pleura. It is performed quickly and it needs little patient cooperation. Whereas the diagnostic, they can diagnose and exclude all the conditions which can probably be visualized by the transthoracic scanning. And all the areas of the lung and pleura are scanned, which is time consuming and needs good patient cooperation. So that is why we'll be discussing about FLUS. So the lung protocols, various lung protocols have been put forward. We have the Blue protocol, which is very famous. It's the bedside lung protocol in emergency. The FALS protocol is fluid administration limited by lung sonography. and cause is the cardiac arrest ultrasound examination. So the flush scanning protocol, there's no international consensus on how to perform flush, but a lot of studies are going on that, and it is performed as part of the other protocols. So flush has been used as EFAST, which is as a part of FAST as extended focused assessment with sonography for trauma, and as a part of FATE and RUSH. FATE is focused assessed transthoracic echocardiography. RUSH is rapid ultrasound for shock and hypotension. So as a part of the FAST protocol, the FAST is a simple, quick, and safe method for the diagnosis of free fluid in the pericardium and the peritoneum. Several studies have demonstrated that the flush performs better than conventional chest X-rays in the diagnosis of pneumo and hemothorax in trauma patients. On this basis, the flush has been integrated with the FAST protocol into the so-called extended FAST in order to improve the diagnosis of pneumo and hemothorax. So here the transducer is placed in 4 positions in the FAST protocol on the abdomen to detect the hemo and the hemoperitoneum or any fluid in the peritoneal cavity and the pericardial cavity. 4 positions for transducer placement are used for the thoracic evolution in EFAST. Sorry. So the 2 anterior positions are used for the evaluation of pneumothorax, and the lateral positions are used for the evaluation of pleural effusion. So on each side of the chest, the second intercostal space, I'm so sorry, it's just moving. So the second intercostal space in the medioclavicular line on the right and left hemithorax for detection of the pneumothorax, and the 4th intercostal space in the posterior axillary line for the pleural effusion. So when flush is performed as part of the FAST protocol, the purpose is to answer the following 2 yes or no questions. Is a pneumothorax present? Is a pleural effusion present? So the scanning zones differ in flush. Each hemithorax is divided into anterior, lateral, and posterior surfaces, which are further subdivided into smaller squares or the scanning zones. So you have 1, 2, 3, and 4 on the right side, and then 5, 6, and 7 posteriorly. Similarly on the left side. So they are denoted from 1R to 7R, the right, and R is right, and 1L to 7L, L is left. So the examination technique, the patient's position in the ICU, usually the patients will not be able to mobilize. So the patient can be supine, and the orientation marker is placed in the cranial side, and the transducer is placed in a longitudinal axis. If the patient can sit, then it can be used for scanning the posterior zones. But if the patient cannot sit, then the lateral position can be used for the anterior as well as the posterior scanning zones. So the probe indicator should be in the cranial position, and in each scanning zone, it is noted whether pneumothorax, pleural effusion, or multiple B lines are present. Normally, the B mode is sufficient to scan the chest, and then M mode or color Doppler can be used in some cases. So let us have a look at the lung anatomy or sonoanatomy. The lung is enclosed within the chest cavity, and the chest wall is constituted by the ribs and the soft tissues, including the muscles, and the alveoli exist in the lobules separated by the interlobular septa. The ultrasound waves are completely scattered and absorbed by air in the healthy alveoli, so the texture of the normal lung parenchyma is not seen. So when you have an intercostal view, when you place the probe onto the chest in the longitudinal plane, you will have to identify the bat wing sign. So you will have to identify 2 ribs. The 2 ribs on either side, which is depicted by the hyperechoic line. This is the hyperechoic line of the rib on either sides. And then below that, you have the acoustic shadow. Because this is a periosteum, you have an acoustic shadow beneath that. And then the pleural line will be around 0.5 centimeters below the rib shadows. And this is usually the parietal pleura. So this is likened to a bat, where the body of the bat is represented by the pleural line and the wings by the rib. So the costia are the hyperechoic surface, and this is the hypoechoic acoustic shadow. So the transducer should be vertical, as I've already told you, and the bat wing sign should be identified before we proceed further. And the depth of the ultrasound image should be aligned so that the pleura is in the center of the ultrasound screen. So this is the longitudinal and oblique views. In the longitudinal view, we have the bat view sign over here. And then once you want to once you have identified the pleural line, then you can go into the oblique or to the transverse view so that a larger surface of the pleura can be visualized and the pathology can be detected. The various pleural signs which are used for the lung ultrasound evaluation between the ribs are the lung sliding, the B lines, and lung pulse. So this is the lung sliding. It is a subtle and bright horizontal movement of the pleural line in synchrony with the respiratory cycle. This indicates the sliding movement of the visceral and the visceral pleura against the parietal pleura. So you're able to see the shimmering movement like an ants in a line. So this is the movement of the visceral as well as the parietal pleura moving together. If they are separated, then this sliding movement is lost and only the parietal pleura will be seen as a bright hyperechoic line. So this, when air separates the two layers, this movement will disappear and the parietal pleura will be visible, but it will become immobile. So lung sliding using the M mode or the motion mode, it is likened to the seashore sign. So where the sky is depicted by the skin and subcutaneous tissue, ocean will be the muscle, and the beach is the lung tissue, which is seen as a sandy appearance. Then lung pulse or lung pulsations. The lung pulse is caused by the force of the cardiac pulsations being transmitted to the lung and hence to the visceral pleura. It is defined as lung pulse only in the absence of the lung sliding. So here you can see the cardiac pulsations, and this will be around 70 to 80 per minute. You can see this movement over here. So it indicates that the visceral pleura and the parietal pleura are juxtaposed at the location of the probe, but there is no regional ventilation. So in these conditions where there is selective bronchial intubation or in the initial phases of atelectasis and pulmonary contusion and hyperinflation, this lung pulse will be seen. So in case of pneumothorax, there will be no lung pulse. The next artifacts are the A lines, which are when the probe should be placed exactly perpendicular to the pleura to visualize the A lines. A little tilt will hinder the visualization. So the ultrasound waves will be reflected between the pleura and the probe. And then they are depicted, they are reflected. And so you have various at equidistant A lines coming below the pleura. So they become less echoic as the depth increases, and they are found in normal healthy tissues, healthy lungs. Then the B lines are, they represent the interlobular septa. They are comet tail reverberation artifacts. 1 or 2 may be present in 30% of normal healthy subjects in the lower lateral intercostal spaces. So when the interlobular septa are filled with fluid, the air and water are hit simultaneously by the ultrasound beams, and these B lines are formed. So this is how they are reflected. So this is the thickened interlobular septa, and these are the reverberations caused by the multiple ultrasound beams. And you have the comet tail B lines which are coming up. What are the characteristics of the B lines? They always arise from the pleural line. They are hyperechoic reverberation artifacts. They are laser beam-like. They move with lung sliding. They are vertical with no fading and extend till the bottom of the screen. They erase the A lines, and they indicate the filling of the interstitial septa. There are some other lines which are seen, which are called the false B lines. The E lines are seen in subcutaneous emphysema. They are well-defined vertical lines arising from the subcutaneous tissue, and they're not synchronous with the respiratory movement, and they erase the A lines. The Z lines are the common artifacts which are present in more than 80% of the population. They are vertical, bundle-like, arising from the pleural line. They are ill-defined and do not erase the A lines, and they're not synchronized with the respiratory movement. The C lines are centimetric in size. They're concave or curvilinear. Subpleural hypoechoic focal images are seen, and this is seen in consolidation. Now, coming to the curtain sign. Inhalation causes the curtain sign at the costophrenic angle. So it forms an air curtain. This is the lung which is moving on to the abdominal structures. So the diaphragm is not visible. Part of the diaphragm is only visible over here. So the movement of the lung during inspiration looks like an air curtain being drawn, obscuring the abdominal structures. So this is usually seen in normal, healthy lungs. So to summarize the normal lung ultrasound, the pad swing signs, lung sliding, A lines, curtain sign, 1 or 2 B lines are seen in the normal lung. Then alterations will be seen in the lung pathology. So the first pathology that we are going to discuss is the pneumothorax. So ultrasound can be used to diagnose or exclude a pneumothorax, to give the indication for drainage, to localize the site of insertion of the chest tube, to semi-quantify the extent of pneumothorax, then detect the residual presence of air after drainage. And in the chest X-ray, the anterior pneumothorax is difficult to visualize in the supine patients. So ultrasound is of great help in detecting a minimal amount of pneumothorax also. And CT scan is usually the gold standard in diagnosing a pneumothorax. But in ICU, when the patient is in the ICU, shifting of the ICU patient from the ICU to the radiology suite, or there can be delays in shifting, then it is cumbersome. Shifting is cumbersome. There can be delay in shifting. And there is also risk in shifting of the unstable critically ill patients and those on mechanical ventilation. So depending on, for all these factors, it is better to use a ultrasound. And it is a boon that we can use ultrasound within the ICU and then diagnose and treat the conditions. So the flush signs for diagnosis and exclusion of pneumothorax, there are 3 categories of signs. The signs which rule out the pneumothorax. These are the presence of either lung sliding, B lines, and lung pulse, and they have 100% negative predictive value. So if they are present, it means that there is no pneumothorax at all. The signs which are suspicious but not diagnostic of pneumothorax, absence of lung sliding, B lines, and lung pulse. So if any of these, they are absent, then you can suspect a pneumothorax. The signs which are diagnostic for pneumothorax, absence of lung sliding, B lines, and lung pulse, together with the presence of a lung point. So this has 100% specificity. And if you find a lung point, it confirms the presence of a pneumothorax. So here we see what the pneumothorax, this is the normal lung, and this is the seashore sign on the M mode. And in a pneumothorax, there is no movement of the chest wall as well as no motion of the lung. So all the lines are stratified. So even the lung tissue will be a stratified lines. So this is called the barcode or the stratosphere sign. The moment the stratosphere sign is seen, you can be sure that it is a pneumothorax. How do you examine for the pneumothorax? When you have to put the probe on the highest point of the anterior surface of the lung. And once it has been assessed and neither lung sliding, B lines, or lung pulse are identified, a pneumothorax should be suspected. And then one should continue the examination in order to confirm the pneumothorax diagnosis by the identification of the lung point. So the next step would be to try to identify a lung point in order to verify the diagnosis of a pneumothorax. So identification of the lung point involves the following steps. Continue the examination with the transducer at the highest point of the anterior surface, close to the sternum. Then rotate the orientation marker approximately 90 degrees counterclockwise. And then adjust the rotation in such a manner that the scanning plane is parallel to the intercostal space and no ribs are visible on the ultrasound screen. Move the transducer laterally in the intercostal space. As the transducer is moved, continuously assess the ultrasound screen for a change in pattern from lung sliding absent to lung sliding present. If a change in pattern is seen, a lung point has been identified and the diagnosis of pneumothorax has been made. If no change in pattern is detected, integrate your findings with the clinical context. So this is the lung point. You have the normal lung sliding over here, and this is the abnormal. So when you come laterally from the abnormal point where there is no lung sliding, there is a point where the normal lung sliding can be detected. So this is called the lung point. So estimation of the pneumothorax, you can even estimate the amount of pneumothorax that is present. So when you see the transition point, so here you can see the air within the chest cavity, within the pleural cavity, and then this is the transition point where the lung point is present. So if the lung point is medial to the mid-axillary line, it means that around 15% of the lung is collapsed and we can go for a conservative management. If it is lateral to the mid-axillary line, then more extensive lung collapse is to be suspected and drainage is indicated. So here again, you can see the seashore sign, and this is the lung point, and this is the stratosphere. So when you come from the anterior to the lateral, at one point, the M mode will turn into the seashore sign. So that is called the lung point sign. So this is again depicting the same thing. This is the M mode with the stratosphere sign. So decision making in pneumothorax, whenever you have to, it depends upon whether the patient is stable or unstable. In stable patients with detected lung point, perform the supplementary imaging to accurately assess the size of pneumothorax. In unstable patients with detected lung point and signs of respiratory failure, needle decompression or chest tube insertion has to be done. Now, I was talking about the lung point may be absent sometimes. So when all the 4 signs are absent, it may suggest a massive pneumothorax, a massive pleural effusion, intubation of a mainstem bronchus, apnea, and large lung bullae. So whenever you have a chronic lung disease associated with these conditions, then you can go for a CT scan. But whenever all the signs are absent, even in a trauma patient, you can consider this as a massive pneumothorax and go for a drainage. Then another condition that we have to see here is the subcutaneous emphysema, which is usually associated with the penetrating chest trauma. It obscures the view of the underlying structures. So these are the E lines that are seen. Potential of the ultrasound examination depends on the outspread of emphysema. So because of the E lines, you're not able to see anything within the lung. So then the flush needs to be submitted, has to be supplemented with other forms of imaging. The next pathology that we are going to look into is pleural effusion. The focused question regarding pleural effusion is fluid present in the pleural space? So the answer will be yes. If it is present, then there will be an anechoic black area between the pleurae above the diaphragm on either the right or the left side of the lower posterior part of the thorax. In the upright position, the ultrasound can detect even 5 ml of fluid and with 100% sensitivity. A chest X-ray usually requires around 150 ml of fluid for detection in the film. So the ultrasound quantifies also the effusion volume. It is as accurate as the CT scan. The echo texture of the collection will also give a clue to whether it is a transudate or an exudate. So in an exudate, the fibrin strands or septae will be hyperechoic, and a transudate will be homogeneously hypoechoic. So this is the depiction of the normal lung, how you see the normal lung and a pleural effusion. So this is the liver and this is the diaphragm. And below that is the mirror artifact of the liver. Because of the reflections between the diaphragm and the liver, the mirror artifact is seen. This is the normal lung. And in the pleural effusion, when you have a pleural effusion, this is the diaphragm, which this part of the diaphragm is usually not seen. So here you have the liver and the diaphragm, and above that is the anechoic area, which is the pleural fluid. And within that, you have some echoes. So what are these echoes? These echoes can be any debris like blood, pus, or cancer cells, etc. And this is the left side pneumothorax, the pleural effusion, sorry. So this is the spleen on the left side with the diaphragm, and this is the subphrenic space. This is the anechoic pleural effusion, which is present here, and the compressed left lung. So 2 signs are helpful when performing the flush for the assessment of pleural effusion. One is the curtain sign, the other is the spine sign. We have already seen the curtain sign in the normal lung. The presence of the curtain sign is assessed by looking in the area of the pleural sinus. So this is the costophrenic recess, where the transducer is placed at the level of the liver, and through the liver, you will be seeing the lung. So the presence of the spine sign is assessed by using the liver on the right and the spleen on the left side as an acoustic window to visualize the pleural space. So here it is through the liver that you are seeing the pleural space. And here again, through the spleen, you can see the pleural space on the left side. So the fluid is present between the 2 pleural blades at the costophrenic sinus. The curtain sign is no longer present. The pleural effusion functions as an acoustic window, enabling visualization of the structures which previously could not be visualized due to the air content of the lung. The size of the effusion determines to what extent the lung is compressed and the number of structures which can be visualized through the effusion. Typically, the most superficial part of the diaphragm can be excellently visualized when an effusion is present. So this is the effusion here, and this is the diaphragm that is being seen, and this is the lung that is collapsed. So as stated, normally the superficial part of the diaphragm is hidden behind the curtain. Next, coming to the spine sign. The spine sign is used when assessing a supine patient for pleural effusion. In this case, zone 5 cannot be assessed, which is because posterior. So instead, the zone 3, which is lateral, is evaluated for the presence of the spine sign. Normally, no anatomical structures in the chest can be visualized next to the profound part of the diaphragm when scanning in zone 3. This is due to the air-filled lung tissue being placed in this area, obscuring the visualization of the spine. If the air-filled lung tissue is replaced by either consolidated lung tissue or a pleural effusion, the spine can be visualized through the pathology, which has replaced the normal lung tissue. This is known as the spine sign. So here you can visualize the spine sign. So when there is no pleural effusion, the liver is present and this is the diaphragm. So the spine is usually seen. This is the thoracic spine, which is seen below the diaphragm. Beyond the diaphragm, you cannot see the spine in normal lung. So, but when there is a pleural effusion, this acts as a window and you can see the spine here. Here you can see the spine above the diaphragm. So whenever you have a pleural effusion, you will be able to visualize the spine above the diaphragm also. The other signs that are seen with the pleural effusions are the jellyfish sign, where the tissue, this is the lung tissue, it moves like a jellyfish within the pleural fluid. And the sinusoid sign, this is the M mode. This is the sinusoid sign. When you go for the M mode, the movement of the pleural fluid of the lung is seen as a sinusoid. This is also confirmative of a pleural effusion. Next is the quad sign. When you have a longitudinal view, and these are the two ribs with the acoustic shadows. So if you have two sides of the acoustic shadows, and this is the parietal pleura, and this is the movement of the visceral pleura of the lung. So it forms a parallelogram where you can even assess the volume of the pleural fluid with this. So this is called the quad sign. Then you have the plankton sign, where you have a lot of dots within this one. This is all the heterogeneous dots that is present because of the debris that is present. This is called the plankton sign within the pleural effusion. Hematocrit sign, sometimes the RBCs, if it is a hemothorax, they settle down in the pleural cavity and this forms the hematocrit sign. We have the anechoic clear pleural fluid above and heterogeneous pleural fluid below. This is called the hematocrit sign. And you also have sometimes loculated pleural effusions, which are seen here. This is the lung and this is the loculated. You can see the locules over here. Loculated pleural effusions are seen. So how do you estimate the volume of the pleural effusion? The volume can be minimal, moderate, or massive. So this can be assessed based on the number of scanning zones involved or by simply eyeballing. And then for erect or seated patients, there are various formulae that have been put forward. The GOEC formula is the estimated volume in ml is equal to X plus LDD into 70. So X is the craniocaudal extent of the effusion at the dorsolateral chest wall. And LDD is the lung base to the mid-diaphragm distance or the subpulmonary height of the effusion in centimeters. And for the supine patients, the Bullock's formula is used. The estimated volume in ml is equal to 20 into X, where X is the maximum perpendicular distance between the pulmonary surface and chest wall at the maximum expiration in millimeters. Now, next, coming to the next pathology, which are the B lines. We have already seen that B lines less than 3 are common in the basal zones, but when they are more than 3, and these are called the focal B lines, when they are multiple. So the focal B lines are multiple isolated B lines. They can be normal or pathological. So in multiple B lines in the lower lateral is normal in 25% of the patients. If they are seen in localized increased, they are seen whenever there is an increase in the density of the lung. So when they are localized, they can be because of pneumonitis, atelectasis, pulmonary contusion, pulmonary embolism, pleural disease, and malignancy. Here you will have to correlate with the history and clinical examination to distinguish. So the interstitial syndrome. So how do you diagnose an interstitial syndrome on the ultrasound? When there are multiple B lines, they are seen almost universally in both the lungs. It is called the interstitial syndrome. The criteria are the positive scanning zone is considered when there are 3 or more B lines in a longitudinal plane between the 2 ribs. And 2 or more zones are should be positive on each side. So 3 into 2 into 2. So when it is 12, then you can say that it is an interstitial syndrome. So what are the causes of the interstitial syndrome? Cardiogenic pulmonary edema, non-cardiogenic pulmonary edema, interstitial lung diseases, pneumonias, ARDS, acute chest syndrome, drowning, contusion, etc. So this is how it is seen in the ground. Whenever there is a ground glass appearance on the CT scan or on the chest X-ray, it is seen this way. So pulmonary edema can be cardiogenic or non-cardiogenic. So how do you distinguish? Whenever you have an interstitial syndrome in acute respiratory failure, usually it is a cardiogenic. So if you have to distinguish it from non-cardiogenic pulmonary edema, then you'll have to go for the focused assessed transthoracic echo. And in acute exacerbation of COPD or asthma, interstitial syndrome will not be seen. So there are some ways to separate cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. So it depends on the B-line frequency. In cardiogenic pulmonary edema, they are variable and it correlates to the lung water. In non-cardiogenic, they are numerous, around 3 mm in thickness, always alveolar involvement will be seen. And diffuse parenchymal lung disease, variable, more thicker B-lines will be seen in advanced disease, around 7 mm. So B-line distribution is homogeneous and diffuse. And here it is non-homogeneous and diffuse, and there are spared areas. So here there is continuity in the involvement, but here then some spared areas will be seen. And diffuse parenchymal lung disease also, it is non-homogeneous and commonly basilar. Lung sliding will be present in all, but it will be reduced in the non-cardiogenic pulmonary edema because the pleura may be involved. Then the pleural line will be regular in cardiogenic pulmonary edema, and it will be thinned out also. And here it is irregular and thickened and sometimes fragmented. Effusion is likely in cardiogenic, and it is possible in non-cardiogenic and diffuse parenchymal. Subpleural consolidation will definitely be absent in a cardiogenic pulmonary edema. In non-cardiogenic and diffuse parenchymal disease, it is likely or possible. Echocardiogram will distinguish all the three. Then you can see the LV dysfunction and possible RV dysfunction in cardiogenic pulmonary edema, possible RV dysfunction in the others. So in ARDS, which is commonly seen, I just wanted to highlight that there is the spared area. This is the spared area which is seen. These are the B lines which are present, but the spared area is seen in ARDS. So now how to distinguish the differential diagnosis of acute respiratory failure by ultrasound. So it is the ultrasound is sensitive to the changes in the lung aeration intensity, and 3 patterns can usually be seen. The A pattern, where there is a normal parenchyma and air is increased. The B pattern is where there is increased lung density. More than 3 B lines are seen in an intercostal space. And there is a consolidated pattern where there is no air, either complete deaeration or it is filled with fluid. So you have to scan the anterior, lateral, and the posterior zones. If an A pattern is seen and normal aeration is present, you will have to look for the lung sliding. If the lung sliding is absent, you will have to suspect a pneumothorax, and lung point will confirm the presence of the pneumothorax. If the lung pulse is present, there may be impaired regional ventilation, as in COPD, asthma, atelectasis, or hyperinflation in mechanical ventilation. If the lung sliding is present, plus there is a subpleural consolidation, it can be a pulmonary embolism. So to distinguish, you can do a cardiac ultrasound and the vascular ultrasound to detect deep vein thrombosis. If it is a B pattern, it depends upon whether it is a focal B pattern or a diffuse B pattern. Focal B pattern plus a subpleural or monolateral consolidation, you have to suspect pulmonary embolism or pneumonia. And it's a diffuse B pattern, the normal lung sliding or a regular pleura or a bilateral pleural effusion, cardiogenic pulmonary edema. So usually it is cardiogenic pulmonary edema in the ICU for acute respiratory failure. So to conclude, LUS, that is lung ultrasound, has a steep learning curve and is reaching a leading role for diagnosis and monitoring of respiratory diseases in different clinical settings, either in the ICU or the sub-intensive care units or the general wards. It can be used for pleural as well as parenchymal lesions. So the lung semiotics, when correlated with the clinical findings, can make diagnosis and treatment easier, quicker, and safer. So these are my references. Thank you.
Thank you, ma'am. It was a wonderful presentation. You have almost all covered all the relevant topics, both for anesthesiologist and also for critical care physician.
Thank you.
So without wasting time, I ask Madhavi Madam to go ahead with the program.
Thank you, ma'am. We'll take questions in the end of the program.
Okay, sure. Okay.
Now I request Dr. Nagalakshmi to introduce the last speaker, Dr. Venugopal Kulkarni.
Good evening. It is a pleasure to be a part of the Rsacp program, and it is my privilege to introduce Dr. Venugopal Kulkarni, who is who holds a degree in cardiac anesthesia and holds a position in Royal College of Anesthesiologists, and he has almost 12 publications and many poster presentations. He is a faculty in workshops and conferences, and his special interests are in understanding the physiology and physics. And he's a teacher for DNP students since 2018. And over to you, sir. You're muted. Yeah.
Thank you, ma'am. Thank you for the introduction. And I thank for this opportunity, Dr. Naveen sir and Madhvi ma'am, and for the RSA for giving me this opportunity. Think my slides are seen? Yeah.
Yes, sir.
Yes, sir. Yes, sir.
I'm just trying to keep this simple. I'll just tell about the basics of 2D echo. This is the hospital where I work. And sound is a mechanical or a pressure wave. And whenever it moves through a medium, it causes some disturbance in the medium and it gets reflected. And it propagates longitudinally. And so that's how these reflections are used to build the images in ultrasound. And you know all of this. And in the x-axis, there are three things that we need to remember. One is the period or frequency, the wavelength and velocity. So that is the time and length parameters are on the x-axis. In the y-axis, we have amplitude, power, and intensity. The more a particle moves, the more amplitude it has. The lesser it moves, the lesser amplitude it has. So power and intensity are the deductions from the amplitude, whereas in the x-axis, this is time and the length. As sound travels, it gets attenuated. More frequency attenuates quickly, lesser frequency travels for a further distance. If you want to scan deeper structures, we have to use lower frequencies, and the nearer structures we have to use higher frequencies so that the resolution is good. Higher the frequency, the resolution is good. Lower frequency has better penetration. So we have to have a trade-off between the penetration versus resolution. That's how we choose out the frequency of the probe. And there's a half power distance. You know that as Madam was telling, that lungs, they don't allow the ultrasounds to propagate, and is mainly based on the artifacts that we do the lung ultrasound. But for the heart, it has to go through and it has to reflect from the tissues for us to generate an image. So we don't have the option of telling that there is a poor window in lungs, but we have that option in the heart. You know, like we see many reports where there is a poor echo window. And initially, when the ultrasound of the heart started, the waves go through and they reflect, they hit the tissues and come back. So it was represented as a distance versus amplitude. That was called as an A mode. This is still being used in the ophthalmic practice. So it takes a longer time to travel a further distance. So time is equal to depth in ultrasound. And the higher amplitude is now, if we depict the higher amplitude in brightness, it is called as a beam mode. And if we move along one single scan line and if we scroll the paper, like for example, if all the images are coming, like if the stilettos, the ECG is moving and the paper does not move, all the P waves, QRS complex, everything is on the same line. But once the paper starts moving at 25 millimeters per second, we will get the ECG, the P wave, QRS complex widespread like this. Okay. Similar way, if in one scan line, if you move the screen, if we scroll the screen, we'll get what is called as M mode. So there is one scan line but we are getting the M mode. So x-axis is the time and the y-axis is the distance. So what happens over a period of time, we can very well know in the M mode. So as we are using just a single scan line, the temporal resolution of the M mode is the best one. And 2D image formation, you see there are multiple scan lines are there. So because there are multiple scan lines, it will take a longer period of time to form one frame. So the frames that are formed per second will tell us about the temporal resolution. More lines we have, it will take, the lesser is the resolution, and lesser lines we have, more is the resolution. So we have to be focused in our assessment while we are doing a cardiac echo, because we are seeing the moving structures. And as you know, in the 3D, there are scan lines not only in 2 dimension but in 3 dimension. So the temporal resolution is the poorest in 3D echo. So when we come back to the 2D echo, we have multiple scanning planes like long axis, the short axis plane, and the apical plane. And there are various windows, like you have a parasternal window, you have an apical window, and right apical, left apical, subcostal, and suprasternal. But when we tell parasternal, it's always we mean left parasternal, apical we mean always the left apical, and subcostal. And so practically there are 4 areas. One is the suprasternal, parasternal, apical, and subcostal. We'll see what are these windows. So one more thing that we need to remember is the orientation marker. So in all the ultrasound, whether it is a curvilinear probe or in the linear probe, the orientation marker is depicted on the left side, but in the cardiac ultrasound, it is depicted on the right side. So this is the right side of the screen that we can see. So this orientation marker will coincide with our orientation marker that we are going to scan. And there are various movements when we are doing echo that they are described, like a smile, tilt, rotate, slide, rock, angle, and sweep. Okay, so these are there so that we have to standardize the movement, so that when we are communicating with one another, we need to get these. And when we are practicing also, we need to understand these movements so that we can get a proper image. So tilting, just by, for example, if we are doing a subcostal, just by tilting the probe so that we are just angulating the scan plane from, for example, from 1 scan plane to 4 scan plane with bust. So just by tilting the probe, we can get all these images in a different scan planes. Rotation, like when you are coming from parasternal, long axis to parasternal, short axis, we are rotating. Okay, and then sliding along the rib cage. When we are sliding, it's called as a sliding movement. Rocking movement, small adjusting movement, so that we can get the point of the area of interest, that is called as a small rocking movements. Okay, angling, there is a small difference between angling and rocking, but we need to understand the small movements that are there. And then when we do all these things together, that's called as sweeping movements. Coming on to the parasternal view, we have long axis view and the short axis view. When our orientation, the pointer is towards the right shoulder, what we'll get is the parasternal long axis view in the second or the third intercostal space. When we rotate the marker to the left shoulder, we get the short axis view. So on the left side, we can see the long axis view, and on the right side, we can see the short axis view. When I freeze it, so in the long axis view, what is seen the most superficially is the right ventricle, and then we get the interventricular septum, and then we get the ventricle, and then this is um, the posterior wall, and then this is the aorta, and then this aortic valve, and this aorta, and then what we get behind the aorta is the left atrium, and behind the left atrium, what we see is the descending thoracic aorta. So the relative sizes of the aorta and the LA are seen to see because they are almost of equal size. And when we pass our cursor through the mid-papillary line, that's where we get the M mode, and then we get to see the fractional shortening, from which we get our ejection fraction. And coming back to the short axis view, in the short axis view, we see all the segments there are 6 segments of the LV. So we can see the, like, for example, this is the LV, this is the anterior wall, this is the inferior wall, this is the lateral wall, and this is the septal wall. So again, septal wall is anteroseptal, inferoseptal, and lateral is anterolateral and inferolateral. So that there are 6 walls, they are divided. And then we can, if we see at the basal level, they are called as segments. And then again, if we see at the mid-papillary level, these are again 6 segments. And we go at the apical level, there are 4 segments, because there are no this differentiation in the anterior, lateral and the septal wall into 2 walls, 2 segments. So there are only 4 segments in the apical, and the apex itself is 1 segment. So there are total 17 segments. So these are described, like when we are communicating, we need to understand this to tell that where exactly is the regional wall motion abnormality, and also to know which area is being affected when there is ischemia. And coming on to the apical, so we can feel the apical impulse, and then we can put the probe there with the orientation markers to the left side. Okay, so then we'll see this 4-chamber view, and on this left side, right side of the screen, we see the left ventricle, and left side of the screen we see the right ventricle. And this is the tricuspid valve, this is the mitral valve, this is the left atrium, this is the right atrium. And then this one is helpful for us to know the longitudinal movement of the ventricles, and also to put the strain, and to calculate the strain, longitudinal strain, and also to see the TAPSE, MAPSE, and tissue Doppler of the annulus. And if we tilt the probe a bit anteriorly, we'll get the aortic, because aorta is a bit anterior structure. So if we tilt anteriorly, we'll get this aortic valve opening. So this position is from the 4-chamber view, and we go into the 5-chamber view. This is very much aligned to the for our Doppler, so that we can see the LVOT Doppler, we can get the aortic Doppler. So when we do a pulsed wave of the LVOT, we can calculate measure the VTI. VTI means velocity time integral. That will tell us about what is the, and with that, if we multiply the area, what we'll get is, we'll get the stroke volume. Okay. So apical, again, we can have a 2-chamber view and also long axis view. Long axis view and the 2-chamber view will help us to understand again, we'll be able to Doppler them in the long axis view, the Doppler of the aortic flows. Okay. And in the 2-chamber view, we can see the anterior wall and the inferior wall, so that we can see the regional wall motion abnormalities there. In the short axis subcostal, we have one more window called a short axis subcostal view. And in the subcostal, we can either have a short axis or a long axis. Okay. In the short axis, we can see the 4 chamber. We can see all the 4 chambers with the heart, and it's the best view to see if there is any ASD or a VSD, and it also tell us about the function of the heart. And it is also very good when, while doing resuscitation, we can scan the heart in the subcostal, and it's also best view to do the pericardial tamponade, pericardial centricis if there's a pericardial tamponade, so that it's helpful in resuscitation of the patient. And then in the long axis, we can see the volume status. Everybody doing in the ICU practice, they are very well aware of the ICU, IVC, how much it is filled, how much it is moving with respiration. Based on that, we can calculate the volume status of the patient. And then suprasternal, not much used in the anesthesia or the practice, but this is the aortic arch that we can see. And then this is the RPA, that this aorta loops over the RPA and then comes here like that. We can see helpful in establishing a communication between, if there is any presence of any communication like a PDA between the aorta, or we can also see that if there is any coarctation of aorta from the suprasternal notch view. Okay. And then coming on to this is an important view. This is the most thing, the plaques view, LV view. This is the most commonly done by the cardiologist, the first view. And then they calculate this fractional shortening. Based on this, they will give us the ejection fraction. in the anesthesia practice especially, we'll just see, okay, if the ejection fraction is fine, more than 40%, we got 45%, we can go ahead with our anesthesia. But this is just a single dimension from which they will just see this dimension D3 from which it is calculated, and it is only one scan line from which it is calculated. So we have to be very careful with the drawbacks of this ejection fraction. So this is just one echo report we just see, but we have to make it a point that we see the echo loops also. We should be able to understand the echo that is done by others. Just by seeing a report may not be helpful. Unless we know, for example, ejection fraction, if we say, if there's a 2 ml and if 1 ml is coming out, then the ejection fraction is 50 ml. If it is 50 ml and 25 ml is coming out, it's still 50% ejection fraction. So, but the stroke volume, there's a huge variation from 1 ml to 25 ml. So, it does not really tell us about the cardiac output. So, it's just a fraction which we have to be careful of. And then fractional area change, at least here when we are doing in the short axis view, we can see what is the fractional area change instead of, just by the single line, there is a single fractional shortening here, we are seeing the area change. This is a bit better, predictor of the total volume change. And also we can calculate the ejection fraction itself by the Simpson's method. But routinely we don't normally follow because it is a bit time taking. And one more thing that we can do in the ICU is to follow a trend of, we can measure the LVOT area, and in the same place we can get the LVOT VTI, and then we can, because the area does not change much, just following the VTI trend, we can trend, because LVOT VTI multiplied by the area or the area of the LVOT will give us the stroke volume. Stroke volume multiplied by the heart rate will give us the cardiac output. Just by trend of the VTI will tell us in which direction the stroke volume is going, and based on that we can see the cardiac output. But we have to be careful that in arrhythmias it may not be very useful. Okay, and again there are fallacies of the ejection fraction in mitral regurgitation and aortic regurgitation, because there will be a lot of things wasted cardiac output that is generated from the heart that may not reach the circulation. And the same thing, like when we say, tell us about aortic stenosis, when we are calculating the peak gradient, if the LV function is not great, then the peak ejection fraction, peak pressure gradient may not be. It does not, the reduction in the peak pressure gradient does not necessarily mean that the aortic stenosis is improving, but the LV function is failing. Just skip these things. And there is, like, we have to be always, mindful of the existence of diastolic dysfunction. Just the word of a diastolic dysfunction. If, for example, if we are adequately filled, then there will be adequate generation of the stroke volume. If, for example, just to give an analogy, when we are serving with a spoon, and if for example, if you are taking with a sambar spoon, and then you can fill it, empty it nicely, and if you take a small chutney spoon and then you take the sambar, so even though the heart rate is, like, you put multiple times, the stroke volume that's generated is less only. So it's just like that. If your filling is less, your output is also less. So just remember this analogy. And then, so even with high ejection fraction, we can have a low cardiac output. And one of the things that is a poor echo window we see when we call the cardiologist for the ICU for an echo report, but still there will be, they will tell about a moderate ejection fraction, good biventricular function. We can go ahead with the moderate risk and maintain blood pressure and avoid fluid overload. All these things will be advices given in spite of having a poor echo window. Take this report with a pinch of salt, and better, I think we should do more echocardiogram bedside, and we should understand that orientation marker. We should do small movements, because the intercostal space is a small one. To get, if you do big movements, you may just miss the image that has already generated. So make small adjustments to your probe and practice mainly the plaques view, short axis view, 4-chamber, 5-chamber, and subcostal view. That will give a lot of information regarding the cardiac function, the volume status, and it also helps to understand not only the anatomy but also the physiology, because we are seeing the moving heart. And we are seeing the moving heart, but we have to always remember that it is not the heart that we are seeing, it's the image of the heart, and there can be a lot of artifacts that we need to keep in mind. And transthoracic echo is non-invasive, so do not hesitate to take the probe and generate those images and interpret them. And always remember that ejection fraction is not the holy grail. Don't base your clinical decision just based on single ejection fraction. So there are a lot of things that are there around ejection to make a decision based on ejection fraction. Thank you very much.
Now open for the discussion. If anyone have any questions, please ask. You can ask any speaker.
Nice presentation, Venugopal sir. First of all, I was thinking how you'll be able to cover the whole of echo. Whatever you have given is just an eagle's eye. There is a lot in echo, and once we keep on doing only, we will be able to understand the dynamics of the heart, and we'll improvise only with practice. And
Yes,
like I'd like to insist, if there are any PGs or anybody, just don't go by the echo report. Like sir said, EF is not the only thing which we look at the echo. So you look at the numbers. Once you start looking at the numbers, you'll get memorized. They'll get memorized and you'll know what it is actually. So please do echoes. And now that we have so much experience with ultrasound, and sound waves are actually friends to anesthetists nowadays. So please practice doing echo.
So basically, practice is the secret.
Yeah.
Any patient you get, no, I let it be pre-op or post-op. I think the PGs, they should hold the probe and just keep navigating, then only you will be able to, it is not, you may find it difficult to get the views initially, but you keep practicing and keep navigating, you'll definitely get the views.
Yeah, first step is getting the views, and don't stop there, because the thing is, like, you have to understand them and make a clinical decision based on your echo, that what you are seeing. So for that, the getting echo views is easier, but making a clinical decision based on what
Interpretations
you
is
get
very,
is,
very
it will take some time. That's a lot of learning curve is there.
learning curve is very good, very steep in echo. So it takes a lot of time to interpret and learn and understand the basics of echo. But with time, I think with time and practice would make somebody perfect with echo. And it was a good overview of an echo.
Thank you, ma'am. Questions?
Any questions in the chat box? Let's see.
Hello, Venugopal sir.
Yeah, hello.
Yeah, I'm Shravan sir. How are you?
Fine.
Sir, I just joined in the last part of your presentation.
Yeah.
Amazing. It was really good. And one small suggestion, sir. Can't we suggest the government, state government, on behalf of ISC to include the echo and to provide the ultrasound machines and also echo probe attached to it in all the government medical colleges? Because uh, in Kaktiya Medical College and MGM, we have worked for almost 20 years, still associate professor, but no ultrasound machine was provided. And in new medical colleges, which they have started in 2022 and 2023, they have supplied the ultrasound machines, which are really good. Like sonosite machines, they have good. But there, the postgraduates are not there. In all the old medical colleges, the postgraduates are there. Forget about the A category seats in private medical colleges. And whatever we say, like for the last 20 years, we have been listening, but there is no proper curriculum and there is no proper orientation and teaching towards the cardiology for anesthesia postgraduates. So whatever we learn in bits and pieces during post graduation, and only few people they will have an interest to extend themselves in this learning process by working in corporate sector or by working in private sector or do some fellowships or progress towards a DMs of late and continue to accumulate knowledge. But this is not happening on regular basis as a raw, what do you call, like teaching process or coaching process for postgraduates. So this probably can we suggest or can we give a recommendation to the state government, sir? Can we think in that direction?
I think it's a very important, sir. It's a nice, very good suggestion. I believe that echo should be there during our pre-anesthetic assessment of the patients, so that we can make a, like, a good decision regarding clinical management of the patients perioperatively. So that is
See, when we were postgraduates, even in NIMS, we used to do the volume assessment with the help of CVP.
yeah.
Like through this, I mean, central line, what we used to place and correlate with the invasive arterial pressures and the CVP, whether it is like hypovolemic or septic shock or a cardiogenic shock. And to be frank, even I am not confident, though I have become a professor, to assess the volume status with the help of an echo probe, because we are not provided with those machines.
Correct.
And we were just stuck to this government service and part-time private practice as a freelancer. So of course we try to evolve or gather some knowledge and gain some experience with hands-on ultrasound probes or echo. But for a regular anesthetist, whether he is a student or whether he is a faculty, that provision has to be there to hinder him from this learning process. That is what I believe, sir.
Correct, sir. This is the cheapest imaging modality available. Okay.
Yeah.
Even cheaper than X-ray, I think. But there is some, learning curve, and also the safest imaging modality. I
Yeah.
think cheapest, safest, and the return of investment in the clinical management is huge. I mean, there is nothing like ultrasound. I think that's it has to be. I think we have to together. I think we have to suggest and then make it a point that, I mean, this is the language they understand. Return of investment. I think that's what we have to tell them, the government.
Thank you, sir. Right. It was nice to join. I forgot, actually, was in the middle of cases. Somewhere it struck my brain and I could join in the last portion where it was really good, sir. Really a nice presentation.
Thank you.
Thank you.
Yeah, there are no comments. One point to add for the first speaker. I think airway ultrasound can also be used for assessing the endotracheal tube size, especially when you are going for uncuffed tubes in pediatric patients. It gives, it will prevent wastage of tubes at least, but then that way it is economical.
Yes, sir.
Second thing is, madam, ultrasound, lung ultrasound, especially in the intraoperative hypoxia or hypotension. The first investigation should be, apart from your routine monitoring, probably ultrasound and combination of echo, which most of the times we get answers for the difficult questions. And we will get like first-hand information and rapid information. So utilization of ultrasound in combination with echo will solve most of anesthetic problems.
And assessment of tube size probably, will help in not only wastage of tube, but oversized tube cause a lot of tracheal stenosis. If you work in a pulmonology suit, like in a bronchoscopy suit, there is a lot of, post-operative, post-intubation stenosis patients coming and then getting stented and all those things. So we really don't see, I mean, in our practice, we don't see these patients back. So we don't understand the incidence of these patients of developing the tracheal stenosis post-intubation. So that really, probably helps in preventing that also.
Yes, sir. That's basically because of high cuff pressure, sir.
Cuff pressure, yeah.
Sir, request Naveen sir and Vishal sir. Anything is there to add, sir?
I mean, ma'am, it was a wonderful presentation by all the speakers, ma'am. Dr. Pavni's ma'am's topic was so extensive, and madam's topic was so wonderful, and she explained it in such a detail that it was like a kind of reawakening as far as ultrasound lung was concerned, ma'am. Dr. Venugopal, Dr. N. Sunil Kumar, ma'am, they were wonderful topics, and the speakers were wonderful, and so were the chairpersons, ma'am. I would like to take this opportunity to invite and welcome all of you to 34th Annual National and 5th International Conference of RSCP Con 2026 to Indore from 10th to 12th April. You all are kindly invited, and please register yourself to RSCP Con 2026. It would be a great extravaganza. Indore being such a wonderful place, you would get a lot of opportunities to visit the tourist places. Once again, 34th National Annual and 5th International Conference of RSCP Con 2026 will be held from 10th to 12th April. Please join.
Sure.
Thank you very much. It was a great webinar. Thank you, RSCP Telangana. Special thanks to Dr. Madhavi Julakanti ma'am for holding such a wonderful session, for inviting such so wonderful speakers and so wonderful chairpersons. Thank you very much.
Thank you, sir. That's what, sir. People who do not know ultrasound, they cannot do any mission. For example, people who do not know what is Chandrayaan, who explores the Chandrayaan, sir, it was like a Chandrayaan for most of the postgraduates or anyone who does not use ultrasound. So it is on behalf of anesthesiologists, whoever, let's start using ultrasound more and more. Then only you'll be experience and practice, which will be useful. It was wonderful webinar. I thank each and everyone, Dr. Sunil, Dr. Pavani Madam, Dr. Venugopal Kulkarni. They experienced and enriched, really enlightened this today's webinar. I thank all the chairpersons, faculty members, and especially President Research Society of Anesthesiology, Dr. Naveen sir and Dr. Vishal sir. When Vishal sir asked me, I didn't know what topic to be choose, but I know that the capacity of our speakers like Sunil sir, Sunil and Pavani madam and Venugopal sir. I thank each and everyone. Thank you all.
I would like to
Once
call
again,
upon our patron once again, Dr. Tejke Kaul sir, please for the final words, sir. Dr. Tejke Kaul sir, please.
Hello, you want me to say something?
Yes, sir. Yes, sir. Yes, sir.
Excellent program. My one suggestion and request is that all RSCP conferences, whenever held, must have a workshop of focus.
Right, sir. Right, sir.
It should be made mandatory. It should be made mandatory that we hold a workshop on, because this is upcoming and it is the need of the hour, as I said in the beginning, and everyone must know about it, must learn about it.
Your point is well taken and noted, sir.
Thank you, Dr. Vishal. Excellent. God bless you. You are doing a great job.
Thank you.
Great job.
Thank you. Your blessings. Thank you.
God bless you. God bless you.
Long live RSCP, and once again, I would like to welcome all
good
to
attendance
RSCP.
Today there was a good attendance. It touched almost 70. It was good.
Thank you, good. Thank you. Thank you. Good night, everyone.
Good night, sir.
Thank you each and everyone.
Thank you very much, sir.